This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hi, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon in New York and New Jersey.
And I'm Dr. Marina Kurian. I'm a general surgeon in New York City area.
This week, we are not live because Marina and I are taking the weekend to ourselves, and we hope you're having a great time with your family.
But if you have the time to watch our highlight reel of some of the most important topics that we've discussed over the past several shows. I also want you to tell us what's been happening in the ER, because you know what, all of my colleagues across the country, and I do general surgery and minimally invasive surgery, are like, they're going, where are the gallbladders and the appendix? And then what happens is they come in very sick, or their primary care doctors already started them, certainly for appendicitis, on antibiotics at home, so that when the patients are still sick and they come in, they have much more complicated disease, and we're seeing, a greater colon resection. It's a lot more rather than catching something early. So I can imagine with cardiology, initially everyone was like, where are all the chest pain patients? So just let us know what's going on where you are.
Well, so thank you. So you're absolutely right. The nationally, interventional cardiologists started talking about this because interventional cardiology is a specialty that we treat the heart attack patients. And so there had just been kind of our regular level of the large heart attacks that we called STEMIs, and we've had this regular level at our medical center, maybe 15 to 20 patients per month having a heart attack that we have to take to the cath lab emergently. And we noticed when the pandemic was in full bloom that almost came to a screeching halt. And then via social media and going to talking to colleagues, we started to see that was a national phenomenon. And so it made us think one of two things. We said, well, wait a minute, there shouldn't be anything about a virus that is preventing heart attacks, right? That's more inflammation. If anything, that would cause more heart attacks. So I wonder if people are staying home. And then sure enough, people started publishing about it. And when patients did come in with a heart attack, they would tell us that, I stayed home for a day or two or three. Why? Some of it is because of the messages we were sending out, that if you're sick, don't come to the emergency room because the hospitals are overwhelmed and there are these viral particles all in the air. And so people sadly were staying at home with their chest discomfort. And what we started to see a little bit, and I hope we don't see more, are these very late stage complications of a heart attack. So I lecture to our first year medical students about heart attack, and there are some complications of not presenting early with your heart attack, such as the heart tearing, or a part of the heart muscle valve rupturing, or the heart itself basically exploding. But when I lecture for years, I've said, now, you're not going to see this very often because these days we open up and treat heart attack patients right away. But my concern is that now we've actually seen a few of these late stage complications of late presentation. And so it's really sad. So we've got to be careful about our messages, because and I don't mean just my place, as a medical community, we were sending that message out of don't come to the emergency room. And some of our heart attack patients really took that seriously, unfortunately.
So Quinn, I think you tweeted on Monday, and I have to tell you, I was heading into the OR or in between cases or something, and I saw your tweet, and it just made my day, because this 4 collage of pictures that you tweeted show us an EKG when somebody's having a heart attack, what the angiogram looks like, what it looks like when you've cured them, and then you being very serious in your celebration. So I'm wondering if you can talk our viewers through what this is and the magic that interventional cardiology can do.
Oh, thank you. So I think it is, I'm partial, but I think it is the best specialty. It is truly a blast. So I'm on social media, as you said, and we use social media for a few reasons. I'm only on Twitter, but we use it to educate. We use it sometimes for humor. We use it to recruit to our programs. We use it to speak out against injustice and simply to get out some PSA. So here in the upper left corner, you have an electrocardiogram that shows someone, if you're not a cardiologist, you may not recognize this, having a very large heart attack. And to the right, upper right, is an angiogram. And there's the most important of the three coronary arteries is completely occluded. And then lower left, this is what it looks like after we've opened it with a balloon and stent. And for years, I say to my heart attack patient, after we get the artery open, their chest pain gets better. I say the heart attack is over. And my staff got such a kick out of that they had these T-shirts made up. And so 1, 2, 3, 4, this heart attack is over. We have fun with that. But if I want to if I can, I'll take this opportunity to say, please don't stay home. The emergency rooms are safe if you need us. If you're having chest discomfort, call your doctor. If you can't reach your doctor, come into the emergency room. It is safe. We have precautions in place to protect you. We don't want anybody staying home with severe chest discomfort or a heart attack because you're afraid to come to the hospital.
You know, we resumed elective surgery in mid-May, and I do a lot of weight loss surgery as well as some general surgery. And when we started, you know, the hospitals took great measures to try and make sure that the patients would be safe and that there would be virtual. We went for zero transmission of virus. And so far, when we look at the elective surgery schedule at certainly in New York City area, there has not been any transmission. And I actually think, talking to my colleagues across the country, there hasn't been any patient getting COVID from a hospital. And I think, you know, early on, we didn't know what to expect. We only saw, you know, the horror that was going on in Wuhan and Italy. And so we told people to stay home. And, you know, if it was something minor, right? But now we know that we really know how to use PPE appropriately for all of our staff. We know how to protect our patients. And also the patients now know when they come in, if they're wearing a mask and they're doing the social distancing, that they're going to be safe. And I think that is a critical piece to walk away from, especially as some of the states are still sort of surging, which is unfortunate.
When you talked about, if you're having chest pain, don't hesitate to come into the emergency room. We know that women have different types of cardiac symptoms than do men. And we actually know that women come to the ER with cardiac issues, but odd symptoms, and they're sent home, let's say on a proton pump inhibitor or something like that. So I wonder if you can talk to what women should be looking for, or what people should be looking for if their female relatives are having chest pain. What necessitates them going to the emergency room?
Yes. So thank you so much for bringing that up. In fact, I used chest pain, but what I should have used is what I usually use in my patient encounters and what I teach my trainees to do, and that is chest discomfort. I learned the hard way once when questioning a patient over and over again over a number of weeks if he was having chest pain, and he kept saying no, and then he wound up in the hospital on the day I was off and he had a heart attack. I went and peeked at his chart, and his chart said he'd had months of angina. And I went and talked to him, and I said, well, I've been asking you every day if you were having chest pain. He said, well, yeah, you asked me if I had chest pain. I didn't have chest pain. I had chest pressure. And so now you almost have to be a little bit of a detective. So we ask about chest discomfort. The most common symptom of a heart attack is an uneasy discomfort in the chest, pressure, heaviness, tightness, squeezing. However, those are what we call the classical or typical symptoms, but there are unusual or atypical symptoms. There could be back pain, shoulder pain, profound fatigue, breaking out in a sweat. Sometimes it's in the jaw. I've had patients who thought they were having a toothache when they really were having a heart attack. And it turns out, for reasons we're not clear we understand, that women tend to have a higher proportion of those atypical symptoms of a heart attack than do men. What I like to say to people is know your body. Whatever the ache or pain is, you know your body, and you know we all have, I think most of us, our usual aches and pains. But if there's something going on, a stomach ache, your shoulders are hurting, you're more short of breath, you are sweating and you can't figure out why you're sweating, that's a reason for you to, if you can reach your doctor quickly, call them. And if you can't, come into the emergency room. And then we need to do better and better, and we are getting better, about training our healthcare providers, our physicians, our students, residents, fellows, that women and the elderly and persons with diabetes are more likely to have these atypical symptoms of a heart attack, so have a high level of suspicion.
Tamara, can you just go through for our viewership, which is not all medical people, can you let people know what's the difference between ophthalmology, optometry, and oculoplastics?
Okay, I know it's a lot of O's and a lot of letters. Ophthalmologists are doctors of medicine or doctors of osteopathy who have completed 4 years of training after college and then have gone on to a 3-year residency after a year of internship. And part of our training is the entire arena and spectrum of eye care. We fit glasses, we treat glaucoma, we do surgery as well. So we're one-stop shopping. Optometry is a separate allied field that also does 4 years of training. In different parts of the country, it's very state specific, but generally speaking, they do not have the same surgical privileges in most cases as ophthalmologists. We think of them as our teammates in the eye care team, and many ophthalmologists, about half of ophthalmologists, employ optometrists as part of their practice. And one other O that you didn't mention, which sometimes gets people confused, is optician, which is a person dedicated to the fitting of eyeglasses like I'm wearing today. It's actually quite an art once you choose your frame to get the right prescription, so it's the perfect pair of glasses for you. Oculoplastics is an area within ophthalmology. It's quite surprising. Something as small as the eye could have so many different subspecialties. But I chose to specialize in oculoplastics, which is the focus on the area around the eye socket, we call that the orbit, the tear drainage system, as well as the eyelids. So I like to say everything around the eye, but not in the eye.
So I actually celebrated my 25th wedding anniversary at a casino out here, and we went for dinner and we played some golf and stayed in one of the nice rooms there. It was very different for sure, but they had the tables separated to nice. I mean, I think we may be ahead of where you guys are out on this side, but they had the tables about 6 feet apart. The servers wore masks. It was very lovely. We were able to go outside and have drinks, and so it's an experience still. Very, like you said, it's different. We were at a casino; people were wearing masks in the casino, but it did feel it. There was some sense of normal there too, just to be able to go and eat and hang out and have a dining experience was so nice. And our room was perfect. And you know what was weird? There was no way you could get ice. The big change are kind of strange to me, but yeah, there was no way to get ice, so you had to just go drink water or bring your own whatever. But no buffets, nothing like that. But I had a lovely time. It was just a nice experience to just get out. And I think my personal opinion is, if you are concerned, if you're someone who gets very anxious about about germs and stuff, the best thing you can do is protect yourself, because not everyone has the same level of anxiety when it comes to that. We do have Clorox here, so I'll send you some, Marina.
Interstate interdoctor commerce of cleaning products. I like that.
Our own.
I have it in my office, but I won't take it out of the office. I need it there. you know, so I've been just looking for it personally, and it's incredibly difficult to find.
Yeah.
I think Wendy brings up a good point about, I mean, we all have friends and relatives who run the spectrum of anxiety about this disease and how they're going to catch it. And while I haven't left Chicago since this all started, my parents, who live in Minneapolis, did decide that they would brave getting on the road to come down for Father's Day. And so I have to go out and see patients every day. So I figured that I was the vector. So we did try to keep our social distance within my house, and we ate outside every evening. But I think the take-home message is ultimately going back to the very basics, whether you're flying in an airplane, whether you're in a hotel, is to try to avoid touching your face, your eyes, your nose, your mouth, unless you have just washed your hands. Try to avoid being near other people and wear your mask. Encourage other people to wear their masks. I'm going to be thinking about getting on an airplane pretty soon, and the airline industry assures us that they've taken extraordinary measures to keep the air circulating, which is another point. I think when you're unable to socially or physically distance inside a building to try to keep the air circulating with fans, keeping doors open, et cetera. So there are some modifications that we can all make in our professional environments and in our personal environments to try to decrease the transmission. Yeah, the journey may be different, but I think the elements are similar. And I don't know about the rest of the incredible women on this panel, but I think many leaders don't start out saying, this is what I want to do with my professional career. At least that's not the way I looked at my professional career. I think for a lot of my journey has been simply a natural curiosity that's always made me willing to show up at something that I might not have thought I would enjoy. So just recognizing an opportunity, I try to tell my adult children as well as my residents that, you know, when you get invited to do something, take advantage of that. It might not sound interesting on its face, but you'll never know what you might find by simply just being present and showing up at something. And I think another thing that helps when you are climbing the ladder, and I hate to use that term because, again, it implies that you have this destination. But as you're moving through an organization, many times you're going to be the youngest or most junior person in the room. You may be the only woman in a sea of men. You may be the only underrepresented person in a sea of majority people. Whatever it is, you're going to sometimes feel as if your voice doesn't matter or that you don't have anything to contribute. And I try to counsel my mentees that your position, whether it be the one of a few women or the most junior person, that may be exactly the reason why you've been asked to join that group, because you've got a different perspective. You haven't drunk the Kool-Aid. You can come in with some fresh ideas and ask questions that other people don't even know to ask because they've been so accustomed to the way things have been. So I encourage people as they are finding their way in their careers to not be afraid to speak up and to ask questions, because more often than not, that's exactly why they want you in the room. I've also found I don't think any of us gets where we are without people who have seen something in us and who not only mentor us, but choose to advocate for us. And I think showing some gratitude and following up with people, writing thank you notes, following up with an email, that kind of relationship building is critical, because nobody gets where they are without somebody helping them along the way. I think as leaders, one thing that we can look out for is to be that person on the other end, help to support other young, up-and-coming people to achieve their great success as well.
I think, so these are the graphics of our 4 societies, and I really appreciate, Marina and Tamara, what you've said. I think that reflects a great deal of our journeys. Here's the 4 of us. So this is the group picture is Tamara with the board of directors of the American Academy of Ophthalmology. And you can see that the women, first of all, dressed fabulously for this picture. And There are very few, but we can be small and we can be mighty. Wendy giving a talk at the Obesity Medicine Association, Marina speaking at the American College of Surgeons. And then one of the coolest things about being president is that when it's not COVID and you can actually have an in-person meeting, you get to invite the most awesome people to be your keynote speaker. So this is the short person in the picture is me, and the tall person is Dr. Mae Jemison, who is one of my heroes. She's a physician, an engineer, a ballerina, and an astronaut. And the chance to meet these wonderful people, the chance to make a difference. I'm going to jump into my story a little, and I'm going to leave the final wrap up for Wendy on this topic. I'll tell you, I echo everything that Marina and Tamara said, and I'll tell you, once you finally get to the table, that's your opportunity to be yourself. You should lead the way you want to lead. You don't have to be a carbon copy of everybody else. I think when I was president of the Academy and president of its board of directors, I was able to influence with my style, with my inclusion of every voice at the table. We were able to move the needle forward again, as Marina said. One of my greatest achievements was the No More Mammals clause in many of our societies, where the rules got set down that we wouldn't allow any more male-only panels as invited panels at our society meetings. That No More Mammals idea actually came to me from one of our executive producers, the one you guys are not seeing on the screen, Sri Srinivasan. And I think the concept of ensuring gender and ethnic diversity, geographical diversity, is a strength we bring to the table. I was really interested. The Obesity Medicine Association actually includes physicians and non-physicians, and I think that's a really interesting group to lead. And maybe Wendy, you can talk to that.
Sure. So yes, we used to be the American Society of Bariatric Physicians, and what you see there is our rebranded logo, where we changed our name to the Obesity Medicine Association. And the reason was we wanted to be more inclusive with physician assistants and nurse practitioners. And through the course of the time that I've been president, we now have a nurse practitioner and a PA on our board. We have worked really hard to increase their involvement in all of the committees. And it really has been, I think, a very welcome change. It's where we're going as a society. You can try to fight it as physicians, but it's going to happen. So it's so much better to be able to just encourage them. And some of our my our best leaders have come from that background, either a PA or NP, and they just have such unique and great ideas for us. As far as my leadership goes, you guys, you all hit such important things, just great stuff that you said. I think the one thing that for me that I felt very passionate about was that pediatric obesity had a voice. I'm a family practitioner, and I noticed that my society, which had many family practitioners in it, didn't touch on a pediatric obesity. So that was the thing that I sort of drove as I was moving up into leadership. Until now, we actually have an algorithm for pediatric obesity. We are, I would say, the clinical leaders for both adult and pediatric obesity at this point. And we're getting a really new group of folks as pediatricians involved in obesity medicine, which I can take a deep breath and rest now. I think the last thing I'll say is make sure you know when it's your time to step down and mentor others. So one of the things that happened to me is I was mentored by a lovely man who brought me into the ranks and introduced me to everybody. And I've always had my people that I have hoped would follow up behind me, and they are now some of the leaders as I step into my last position in leadership.
And I think that as women in leadership, we did not get here without he for she. Without our mentors, can be women, they can be men, and they can be actually younger people, just because they come up with a great presence or great ideas that help motivate you to move whatever project you're on to a different level. And we do want to do 3 takeaways from each of our guests today. So Tamara, do you want to start with 3 things that you want to leave our viewership with?
I will leave 3 things for our viewership on leadership. Show up, speak up, and follow up.
Beautiful. Very nice.
Beautiful, beautiful. You can say that again, Tamara.
Good.
I will. Show up, speak up, and follow up.
We know that testing, tracing, isolation is the way to go to dampen the incidence of this problem in the community. So I wonder, Heather, if you could talk to that as a community issue, and then we can pull it back and say, what should we do in the schools?
Sure. I think for the communities, the most important points are the things you mentioned, maintaining social distancing and not gathering in large groups. Also, the wearing of masks is critical, really regardless of whatever circumstance you're in. And I think that the community's ability to trace and follow up on exposures to COVID-19, I think are really what is allowing and going to facilitate schools opening, because schools are really a microcosm of their communities, and what's going on in the community with regard to the COVID-19 pandemic is going to be going on in the schools.
So, there's some really great articles coming out. There was an article written by the former director of the CDC and 2 former education directors talking about these sort of 8 steps to reopening the schools. And it was really very detailed about having, as you see, shielding the most vulnerable students and teachers, reducing the risk, as we talked about, with masking and social distancing, keeping the virus out of the school so random people can't come visit. Don't mix groups, so don't have kids change student and staff group, reducing occupancy, maybe teaching outdoors if possible, follow health and safety protocols, and preparing, unfortunately, for inevitable cases. And I wonder, Dr. Goza, Sally, if you can talk to what the American Academy of Pediatrics in its guidance is telling people about these topics.
We actually touch, I think, on all of those 8 points, and that, if we're going to have children back in school, we need to be sure they can do the cleaning and the disinfecting as the CDC recommends. We need to have the classes be able to do some physical distancing. And we actually did talk about, think about doing a lot of things outdoors, if at all possible, to try to keep the children from being in school. And also distancing for the teachers, because we know that adults spread it actually more commonly than children do, or at least the younger children. And so having the teachers not go into the break rooms or into the office and congregating, and having them keep their distance as well. And then mask wearing. I saw something on Twitter today that talked about wearing is caring. And I love that about wearing masks, because that's very true, that wearing a mask is caring about other people. And we really need to make sure and do that. And then the mask wearing of the children, really trying to teach these children that they can wear masks too. It's safe to do that. And a lot of children are really good at it. I'm always amazed at the children who come into my office, and I love it. I tell them, you're rocking those masks, because they keep them on sometimes better than their parents do.
So the 2 types of testing are PCR testing, which often involves either nasopharyngeal swabbing, nasal swabbing, or throat swab. And this tests for actually active viral RNA in you at the time. And as you pointed out, just because you're exposed doesn't mean that you should run out the next day and get a test. Ideally, you would wait 7 days from exposure, because that's the median amount of time that it takes to develop any sort of symptoms or enough particles to even find with those tests. So again, the PCR test is really a snapshot in time. And just because you're negative on one day doesn't mean that you're going to be negative for the next week. So it's really important that you know that a PCR test represents a snapshot in time. The antibody test, on the other hand, is a blood test, and you can do that through a traditional blood draw or a finger stick. And that really represents whether you've been exposed to the virus and whether your body has mounted any sort of immune response to that exposure. It's been shown that the antibodies last approximately 2 to 3 months, and that has implications for vaccines that I'm sure we'll talk about later.
So the pictures that we showed while you were talking, Heather, showed how deep that nasopharyngeal swab does go. One of Hari Kondabolu, who's a comedian, said, "I went for a test and they biopsied my brain because it really goes quite far back." The antibody test is very simple. That was my finger, unmanicured and unlotioned, getting the antibody test, which I'm negative. But I think that these are testing, and I think limitations of tests that parents and educators really need to know about. One of our viewers, Kuna Marora, asked, in your opinion, are kids with well-controlled mild asthma low, medium, or high risk because of their underlying condition, and how should the parent weigh that risk before deciding to send them or not to school? And maybe I'll ask Sally to answer that.
You know, we do know that children that have asthma may be at a little bit of an increased risk, but really at the lower medium level, it's probably not as great of a risk as you would think. I think if you're at high risk, that's something you would want to talk to your pulmonologist about as to how well you're controlled and all of those things. I think if parents have any question about their children and what their risk factors are to going back to school, especially those with chronic health conditions like asthma, they should call their pediatrician and ask them, because those pediatricians know those children, they know how sick they can become, and they know their history. And so I encourage anybody that has a child with special needs, or any parent who's concerned about whether to go back to school or not, to call their pediatrician and have a discussion.
I think also, Sarah and Heather, both of you would agree that a lot of it depends on what's happening in your community as the kids are going to school, and the level of disease that's present in the community before you can say, okay, it's totally safe or not. I mean, I am actually totally okay with my kids going away to college. I feel like they're going to do the appropriate things, and the colleges are being very careful and have a plan and strategy in place to help protect their community. So I've been okay with it, but I think, you know, it really depends on what is going on around and practicing. I'm a huge fan of the mask wearing. Some people say, oh, you know, it doesn't work. I think it's protective. It may not be completely preventative, but protective is good. I like that. We can settle for protective and still think it's a fantastic option. And I think that will help get us back into schools. Because we also had another question when they're talking about, and someone texted, it's hot in Texas, and you know, you have the kids out and it's fine, they're wearing masks in their classroom, but then they go out to recess and it's super hot. You know, are they supposed to be wearing the masks out there, and what will happen? Because younger kids may not socially distance as well as older kids do. What do you guys think about that?
I think that it's been pretty well established that there's less spread outdoors than indoors, and this is the reason for the restrictions that different communities have put on things like indoor dining versus outdoor dining as we open back up the economy and things. And I think the same is true for children. Outside at recess, if they're more than 6 feet apart, the masks may be a little bit less important than they are when they're in the classroom, potentially not as socially distanced because of given limitations of space in classrooms and in schools. So I do think that the point is well taken about the heat and Texas and really a lot of the United States in the summer, but masks are critical as much as we can enforce them. And really, you know, the outdoor exposure and the outdoor space is a much safer one.
Well, school nurses already in the world of K through 12 schools or pre-K through 12 schools have students tracking their immunizations because there are school required vaccines that children need to be in school. And so in some way, that record from pre-K to 12 and even in childcare age is somewhat of an immunity passport related to the community of schools and childcare.
I think, you know, as somebody who's had 4 children go through the system in public schools, and my 4th is still going through, the school nurses are tough, and you can't get past that door without your proof of immunizations, and they keep us up to date, not only our pediatricians, but our school nurses, letting us know what our kids need at what age. I just want to take a quick detour to ask you, if you're watching and you like this and you know anyone who's a parent or a teacher or cares about kids or just wants to listen to really smart ladies talk about stuff, please like and share and tag your friends and encourage them to watch in real time or later on our YouTube or Facebook channels.
Students and managing social emotional situations and fears and anxieties often present with physical complaints. So school nurses may sometimes see that student who is talking about a headache or a stomach ache, and they don't know what it is, and that school nurse in assessing and speaking with and listening to that student may sometimes determine that what's going on has more of an issue with anxiety or depression or fear, and they're able to refer to school-located mental health professionals who can help students with that. So it's so important that school nurses are part of the school community because they get to know students and get to be that trusted adult where students can share what's going on with them.
And I just want to read this comment from Laura Silverman, which I think is really spot on, that poverty and systemic racism has such far-reaching, long-lasting impact on children's health, and that epigenetic trauma will permanently affect their lives. And I think I couldn't agree more that it is so important that, you know, this is another reason that everyone who's involved in public education, but as well private education, is that we want kids to go back to school for a variety of different reasons. And we've also found, I mean, there's a few articles out there talking about how remote learning has been not so good, you know, for the kids that they all talk about, and I'm sure you've heard about this, Donna. I never felt like I slid during the summer, but apparently there's something called the summer slide.
Yes.
Whatever you gained, and then you have to catch up again. So it is a concern, and now we have the COVID slide. I guess we're coining it here. It's the COVID slide, unfortunately.
Right. There is a COVID slide, and what we want is for a safer return to school. We want children to get all that they need because education is their work. That's what they do to grow and to develop. And being able to do that in a healthy situation is important. Accurate and reliable local public health data, including the community's spread of COVID, is very important to know. And so we want to make sure that is considered, and wearing face coverings, washing hands frequently, and adequate physical distancing does work. Whether in person or virtual, we know that there are students who have new or increased social, emotional, and mental health challenges due to uncertainty, to grief, to fear brought on by COVID, and that will need to be addressed. So school nurses and mental health and behavioral providers and schools need to be at the table. And we believe at the National Association of School Nurses that significant federal funding is needed to hire and retain school nurses for public school districts that will prioritize student health and safety. And finally, as the eyes and ears of public health and school communities, we know that the convergence of COVID and the upcoming flu season is ahead of us. And so collaborating with local health departments, school nurses can work to make sure that schools plan, prepare, and coordinate health and safety for schools and for students.
Thank you, Donna. Donna Mazeek is the executive director of the National Association of School Nurses, and beautiful closing words.
Sure. I mean, I think the most important point about school reopening for me is that schools are a microcosm of their communities, and there's no one-size-fits-all answer. And really, the answers to all these questions are incredibly challenging for everyone, both within and outside the medical community. And it has to be science-based, but it has to be locally based, and leaders and communities in different areas, depending on their burden of COVID disease and community spread and percent positivity. I think those are the key factors that communities have to look at when it comes to reopening the schools. And the next point is about vaccines. I think that it's critical that vaccines produce as much immunity as possible. But even if the vaccines were to attenuate the severity of the disease to some extent, that would be a huge win. I think that having a disease is one thing, but dying from a disease is another. And if we could prevent the severe morbidity and mortality, that would be a win for a vaccine. And so just to kind of moderate expectations for what a vaccine can and can't do, I think there's a lot of ways in which a vaccine can be a win for us, both for adult health and for reopening schools. And I guess the last point I would make is about the disparities. And I think that COVID-19 exposed weaknesses in really every facet of our society and of our community and of our hospitals and of our schools. And it really exposed, racial disparities in a way that I think was surprising to some people, maybe less surprising to others. And I think as humans and as healthcare providers, we have to really lead the charge here and focus on why those disparities exist and really center Black and Brown voices as we look forward to addressing these issues.
I wonder, Claudette, if you can talk to us, because you've written a lot about opioids and pain management, and one of the questions that came in was the role for maybe CBD oil for postoperative or joint pain. I wonder if you can talk to us about, COVID is not the only crisis in this country, and the opioid crisis continues. So perhaps you can talk to us a bit about pre and postoperative pain management and how you see our role as physicians.
Well, do you have another? This a lot. So, before we go, I just wanted one more point about the physical exam. You talked a little bit about technology, and we haven't had the chance to catch up for telemedicine physical exam technology. Just you wait. There are going to be so many applications that you can use to measure things and to look at things that a patient can have in their home, that they can say, oh, what's your hand exam like? What's your ear exam like? You point it into your ears. There will be ways that you can look in someone's ear remotely. Just you wait. In a few years or a few months, probably, there will be a way for you to look in someone's ear, because technology and the innovation, especially of people in the United States, because we have such an amazing system where we have people who are entrepreneurs and who want to invent things. We will invent this stuff. That's number one. Now to opioids. So the opioid problem is a big problem. And we as physicians, especially orthopedic surgeons who deal with a lot of painful conditions, were big problems here. We would prescribe a lot of opioids. And we realized this, and we have checked ourselves. There were a lot of regulations that tried to check prescribing, but only when the surgeons themselves really looked at the different procedures and said, all right, so really how many pills do we really need for these procedures? And we looked at them ourselves and we created our own guidelines and we studied this and we realized that, okay, this is how many pills we really need. That's how many we should prescribe. And that's where we saw the real decrease in numbers. We actually studied this too. We published a paper on it. We looked at the effect of the regulations and we saw how the pill numbers dropped. And then we looked at the effect of the physician intervention. So the pill numbers dropped by regulations. And then once the physician intervention happened, they really dropped. So it really does take the physicians to really get in there and look at their own practices and change how opioids are prescribed. The other thing we looked at is telehealth and how opioids were prescribed over the COVID crisis. We have not published this yet. We just submitted it. At our institution, from the beginning of the crisis to the end of the crisis, we looked at all opioid prescriptions. Over the time period, from the beginning to the end, the number of pills and the morphine milliequivalents consistently increased. So over the entire lockdown, we have a formula that we found, and it was our statistician came up with it is Y equals 1.309 times X plus 64.24, where X is the week of the prescription since March 1st. So by week, 1.3 times the morphine milliequivalents were prescribed by all prescribers at NYU via telemedicine. So over the course of the lockdown, probably because no one had access to operations, injections, other treatments, people were getting more opioids. So you have these secondary effects of people not having access to their doctors of increased opioid prescribing. So, there are other things that you can do like CBD oil and supplements, but what happened is people were getting more opioids via calling their doctors, calling their pain management physicians, calling their primary care doctor.
Okay. And Ben, I want to ask you about a few things. A couple of our listeners have written in about trigger finger, about carpal tunnel, and about exercises that you can do at home to kind of, loosen up your joints, kind of do this. Maybe, the four of us probably do this in between surgeries because we're holding our fingers so tight. Maybe you can talk to us about sort of the more common things that we experience with our hands.
So trigger finger and carpal tunnel syndrome are two very common conditions that cause pain in the hand. They're two completely separate conditions, although they can travel together. So for carpal tunnel syndrome, basically your nerve that goes up into your hand is pinched right here in your carpal tunnel, right at the base of the palm. We don't actually know what causes this in most instances. Like if you have a wrist fracture, sometimes that can set it off, but most of the people who have it just have it because they may have, a little smack between the sides of the space that the nerve is in, the carpal tunnel, and the content, which are 9/10 plus the median nerve. So what we do is recommend that they wear a splint for at least 6 weeks at night, just to support the wrist in a good neutral position. You don't want the wrist to be down like this or all the way out like this, because both positions put more pressure on that nerve. So the idea is basically to rest it in a neutral position and allow some of the swelling to go down so that the nerve recovers. Some people have tried doing exercise with carpal tunnel syndrome. I have not seen any good evidence that it actually works. Trigger finger is a slightly different condition. It involves the tendons that go up the finger. And so when they bend down, as they start straightening, the still gets stuck and then snap. And that hurts, that snaps. And it's usually a mismatch, again, between the size of the tendon and the tunnel that it has to go through, the flexor tendon sheath. So what we recommend for that is actually, for mild cases, you can have them do called tendon gliding exercises, where you keep them from bending all the way down like this, where they might get stuck. But we have them get a splint made by the hand therapist that keeps the fingers up like this. And so they're bending just the two joints towards the end. And that allows the tendons to slide in and out. And for mild cases, that does work sometimes. Both the conditions actually will improve with steroid injection, which can be done pretty safely and quickly in the office. It takes about 5 minutes. And both of them, essentially can be cured by releasing either the tendon sheath for trigger finger or the transverse carpal ligament for carpal tunnel syndrome. So if the exercises and splinting, et cetera, don't work, we recommend surgery, and they're both highly effective, those operations.
So Ben, can people do these kind of exercises on their own? Can they take a picture of the screen we just showed and kind of do them on their own, or do they run the risk of hurting themselves? And I'm going to ask you, and then I'm going to ask Claudette the same thing. There's so many exercises available on the internet. Are these safe, or are we putting ourselves in some sort of harm's way?
I don't think it's actually dangerous to do any of these exercises. The question is, which exercises should you be doing for your particular condition? So like the exercise you have up on the screen now, the hand exercise, are generally good for patients who may be recovering from a fracture or wrist injury, et cetera. So you want to move all the joints, make sure they get back to action. But for specific conditions, there may be some exercise that you shouldn't do, and then other exercises that you should emphasize. So usually I recommend they see a therapist for 1 or 2 sessions and get a program going. So the therapist will teach them which exercises are most beneficial for the condition they have, and then monitor, how they're doing it. And then they, if they have a good understanding of, there's no reason why they can't take these diagrams from the therapist and continue doing the program at home. Especially important with COVID, you want to decrease the number of contact points. So it's another thing we've been doing is shortening the amount episodes that they have in person.
Half the battle is making time to do it, right? So while you were talking, I was doing my
I think everybody was trying to do them while we were listening to you.
Where's the ball? That's what I need.
Well, that's half the battle is figuring out which exercises to do, because you're right, Suja. Everything on the internet, there's so much out there, and it's a question of what's garbage and what's not garbage. That's the first question. And the second question is, which one do you use for what you have? So you need to do a lot of looking around to figure out what's the quality of the piece of information you're looking at. And then, is this the right piece of information for the thing that's wrong with me? And that's why we are professionals and do this all the time. So folks who come into the office with a stack of things they got off the internet and start going, well, I read this and I read this and I read this. And I'm like, well, then why are you here? What's the point of you coming here if you are already an expert at this and you looked at everything on the internet? The point of the internet is to maybe help you find resources after you've spoken with me, and I help you guide you to tell you what to look for.
What we're seeing in the psychological area is families being together more than they ever have been. Children home from school, parents home from work, parents trying to work in the house while the children were on Zoom or trying to do their work. So there was a lot of stress and people not having been together for so many hours at a time. And we found that the children were in a state of fear that they could not express. They felt a lot of uncertainty. They didn't know what was going to happen. They were on a strange mode for, they're used to being online and screens, but they're not used to going to school and then having part of their school day on Zoom, part of their school day doing independent work. So we found that the best way to handle things would be for the parents to lead the way and do the 3 S's: schedule, support, and self-care. And in the scheduling arena, we ask parents to create family and individual schedules so everyone knows what they're supposed to be doing and have some kind of structure to the day, because all the structures have been taken away. We want to advise people to put into their daily routine exercise and fun relief stressors that the family does together or the kids do together, or if you have an only child, that the only child does, maybe with their friends online. And we're advising people to get support, that the parents for themselves and help their kids to create an inner circle of support composed of trustworthy, upbeat family members, friends, and colleagues. And that's very important because there's so many stresses going on that you really need support, and you need people to hear what you're feeling and people to give you some advice. So that's very important.
You have been in this period of great transition where not only are we learning about a new disease, but we are learning about different ways to teach during this disease, different ways to allow you guys to become the best doctors so that when we get old, we have amazing doctors to take care of us. So Carmen, I wonder if you can talk a bit about your experiences at Meharry Medical College and what do you think has changed for the good and for the bad?
Okay. So I'm currently a 4th year. Actually, I am officially a 4th year as of because all of these changes happened with our curriculum. So we delayed and we had to figure it out. So I should have been a 4th year a month ago, but Friday technically was my official last day of my 3rd year rotation. So I'm very excited about that. But actually Meharry, so we're in Nashville, Tennessee, and we're actually the testing sites for our national population. So we've been the ones that have been administering the test. And at first, in March, the students were able to help. So me and my friends, we were out testing, and we were all geared up from head to toe about. And I think at first people were really scared to just leave the house. So there wasn't a lot of testing at first, but then about a month in, it surged. So I think we're serving over 1,000 people a week or something. And we have a lot of testing sites now. We have at least 4 or 5. I should know that. But we have one on the main campus. We have one at our stadium and one at a Kmart, and then some other sites too as well. And we've been partnering with some local churches as well. But that first month, I would say March, we didn't know if we were going to shut down school. We didn't know what was going to happen to our rotations. I'm a third year, so it's been really tricky for us because we're in the hospital, and we have to see patients. So for a while, they took us out of the clinic, and then we started doing electives, online electives that we would be doing for our fourth year anyway. So I thought that was a really cool transition that they did. So they allowed us to keep on track. So, we were all very worried about how are we going to graduate? Is match day going to be the same day? How is, the application cycle going to work this year? What about CS? So I think the good things that happened definitely were we're still on track to graduate on time. And I think that's, for me, that's probably super biased. But I'm really happy that I don't have to think about, will I graduate in May? And then also having that time away where we were able to do our online electives was really beneficial. I actually went home, so I think it was very interesting that you were talking about the children that were going home. So I'm currently 27, and I went home for, I would say, about a month, and with my mom. And I was really scared too, because I had been doing the testing and all this stuff, and I had no idea if I was exposed. So I did a mini quarantine, and then I went to Georgia to my family. But I will say the bad has been, you don't know which patients are COVID positive, because we have such a high amount of people who are asymptomatic and don't have any symptoms. So even when we do our screenings and we try to make sure that, so as students, we're not allowed to go see COVID positive patients or patients who are symptomatic with the kind of stereotypic signs of shortness of breath and fever and things like that. So we're not allowed to go see those patients. However, you kind of have to treat everybody as if they're COVID positive. And at first, when we first went back, it created this dynamic where you don't feel close to your patients. It's different. You have all these things that are kind of not in the way, but you have a lot of anxiety. I think as time went on, we got a little bit more comfortable. At least I did. But you really do. You have to treat everybody as if they're positive, and it's kind of scary. So, but I think, I'm not exactly sure where our future is from now. I'm a little pessimistic about it, to be completely honest, but I've been finding the bright side, and I bought a whole bunch of different masks in different colors, and that's been my way of keeping positive in the pandemic.
As far as psychology goes, everyone is on Zoom, and we've had a big challenge. We have kids as young as 4. So how are we going to do the therapy session where half the session the kids talk and half the session the kids play? And we needed to do a lot of creative work for this. So I brought into my practice people who were teaching, had been on Broadway, and were teaching kids drama on Zoom and doing, activities, drama activities, and all kinds of skits on Zoom. And we brought in people who were in the occupational therapy and art therapy to do art therapy for half of the session, on Zoom. Our patients right now do not want to come to the office. I'm still in LA. It's the longest period of time I've ever been away from New York. And my daughter and I have been quarantined together with another friend of hers. And we pretty much, except for going for groceries here and there, have just been with each other. And so I'm experiencing what my patients are experiencing. And the patients that are on Zoom, we're finding 2 things. It's not the same as being in person, but it's really a good second best. Zoom and FaceTime and Skype have worked for us, and we've started new cases, and we're doing consulting to the schools, because the schools in New York, some of the private schools are going to be hybrid. Some kids are going to be in the classroom, and some kids are going to be on Zoom, because a lot of the parents will not send their kids back to school in New York. So we're doing well with Zoom. I think some of the psychology people are getting Zoomed out, in my practice, we spread out the sessions so that we don't have 8 hours or 6 hours straight on Zoom, because it gets to be a bit much. People get zoomed in.
I'm from Atlanta, and Atlanta has a huge, huge professional African American society. I don't want to say society, but I mean, it's everywhere. So for me, I'm very fortunate that I never had that. I never saw any doctors that looked like me. My pediatrician was a Black woman. Like I said, my grandmother's dermatologist is a Black woman. There's just there's so many Black doctors in Atlanta, and or Black professionals in general, that for me, I didn't grow up seeing that it couldn't be achieved. However, when I went to North Carolina for undergrad, I realized quickly that Atlanta's not the same everywhere. Like, that's a very unique thing to Atlanta. And I really didn't realize that. I truly didn't. And I can understand how my friends and other people who were interested in medicine, you know, they may have not have seen a Black doctor, or not in person, or like, you know anybody that is a Black doctor. And I mean, that hurt my heart. Like, I mean, I'm so fortunate. But I never felt that way, that I couldn't do this because I've never seen anybody who looks like me who did it. It was just something, it was another job that people had, just another job, and that one that I wanted. So I think it really does play into like that thing, like if you don't see it, you don't know you can do it. And it's not that it's impossible. It's not that it doesn't happen. It just makes it a lot harder to visualize the path and visualize yourself going on that path. So it has a lot to do with it. And I chose Meharry because, one, like I said, it has such a historical impact in my community. Almost every Black doctor, especially the older ones, they all went to Meharry. It's, you know, kind of the end-all, be-all school for Black doctors. So that's something that's really personal to me, as well as their mission. I feel like they're very mission-oriented, and it's not, they don't just say that they're mission-oriented. They do it. We work with the underserved. That is our population. That is the population that we've always worked with, and we always will continue working with. And of course, does that come with, like, you know, some other stuff? Yeah. Like, so sometimes we have to realize, like, resources aren't equitable. And how do we navigate that? So for me, coming to Meharry was one, twofold. Like, I love it here. I feel supported. I have lots of friends and doctors and attendings and residents and staff that look like me, who support me, who can understand my my cultural aspects, as well as they're working with they're working with the African American population, and that's their goal, and as well as others that are underserved. So it's where my heart is, and what I want to continue to do.
Yeah, I think you joining in family practice is definitely that. I think across the country,
yeah,
you know, family practitioners take care of the majority of Americans, and I think that that's incredibly important. You know, we're talking a little bit about, you said, the disparities of care and access to care.
Yes.
We had a couple of weeks ago talked about that whole #MedKini crisis, right? There was an article that was basically looking at vascular surgeons, recent graduates, and pointing out inappropriate social media posts. And this is something actually from you that you popped up in response to that. And there's so much about this picture I love, but why don't you guys were celebrating something, and also I think you made a great point against the profiling and the bias that's inherent to some of that research. Carmen.
Yes. So this picture we took after we took step one. For those who are not in the medical field, step one is the scariest, most horrible, awful exam ever. So we decided to take a trip after to celebrate that, and we had our red bikinis, and we were on the beach, and we had a good time, and it was nice because once again, Meharry has afforded me to have all of these friends who look like me and who share a lot of similar experiences with me, and we're all celebrating, and we're just, you know, being normal. And I put this picture up, oh my gosh, like almost a year ago. And for the MedKini, or the the paper to come out, it qualified a lot of my fears that one, you're being stalked. And you're being
it's there forever, Carmen.
You're being stalked and you're being criticized. And even I remember putting that picture up and I was like, oh my gosh, I asked everybody if they were okay with it, and like, you know, we're all going to apply residency soon. Like, I wanted to make sure this is as professional as it could be. Like, so it's funny that I actually made sure that it was as professional as it could be. And then it was still kind of deemed in this unprofessional light. And then once again, like we've been talking, race really plays a huge part of this too. Like, you know, it's no secret that Black women's bodies are hypersexualized and viewed differently than other counterparts. So that's another thing that went into, like, should I post this? Should I not post this? Type of thing. And it's just, I mean, it's exhausting. And you're so scrutinized all the time in medicine for your evaluations, for everything, from yourself even, that it's just kind of, it becomes overwhelming. But yeah, so of course they didn't say anything about the guys, you know, at the beach, you know, in their trunks or whatever else. But of course the bikinis or the bathing suits was the line. And it's just kind of like, wow, just another thing that is striked against me.
Very quickly on, we became aware when COVID struck that it was disproportionately affecting people from a Black, Asian, and minority ethnic background, both in terms of healthcare workers and also in the general population. So although the work that I did, and I was chair of the Task and Finish group at the Royal College of Psychiatrists in the UK, which is the professional body for psychiatrists, although we led on the work for mental health care staff, the principles and the general points that we recommended are applicable across a variety of healthcare settings. And subsequently, we had national guidance coming out from organizations like Public Health England, NHS providers, you know, a British Medical Association. So a range of bodies also have come up with guidance. But essentially what we did is 2 pieces of work as part of the Task and Finish group. And we now have a work going forward, which is hopefully going to look at issues beyond COVID. So although COVID has amplified the inequalities and the problems we have, we want to make sure that the work that started now to address these inequalities is sustained beyond COVID, because we need to bring about long-term structural change if we are to address these inequalities and reduce them in the future. So the 2 pieces of work we did, one was something which would help us address the situation very quickly. So what we did is come up with guidance that I think you were just showing, which was about making sure that we were able to capture the risk that staff faced in healthcare settings very quickly in a structured, sensitive, and stratified manner, so that we would then be able to put in place some risk mitigation for those staff. And we were very clear in saying that we need to do it for 2 reasons. One is it's the right thing to do, to protect people's lives and, you know, protect staff. Also, if we know that there's a disproportionate impact on some groups, we need to address that. But very importantly, unless we look after the staff, we can't continue to provide the services that people need. So what we did is we said that firstly, there should be a risk assessment process, which should be a conversation between the employee, the staff member, and their line manager. You know, in the case of medical staff, it would be clinical director or medical director. But in other healthcare staff, the line managers, so that we understand the risks that the employee faces in terms of ethnicity, gender, medical conditions, the role they do, the settings and the environment they work in, etc. And then there's a plan. And what we also said as part of that guidance is we said that organizations, that is in the UK, the vast majority of healthcare is provided by the NHS, which is publicly funded. So we said that in the NHS and in other healthcare settings, and even in social care settings, these are the things that organizations can do. So right from identifying this issue, that is the risk faced by BME staff as a risk to the whole organization. So right from that to looking at how you create safe spaces for staff to talk about their needs and issues, how to raise concerns safely, how to make sure that we've got aids for remote working, PPE, redeployment, etc. So an organizational approach and culture led by the board and looked at as a key quality and safety issue. So we made recommendations around that as the first guidance. And the second guidance was recommendations that we made to the Royal College of Psychiatrists, but it was intended to be more long-term. So addressing some of the structural issues around why are we in this situation where there's lack of representative leadership, lack of a full understanding of the issues. So we looked at how we could address training, supporting managers, looking at the equality, diversity issues, looking at how we promote talent in people from minority backgrounds. So we made a set of recommendations to the Royal College, which is again applicable across a range of settings.
I want to get back to being Indian and Indian expat. So about 60,000 Indian trained physicians practice in the United States, the United Kingdom, Canada, and Australia. And that's actually about 10% of the Indian physicians trained in India are all emigres. So India actually exports the most number of physicians. As of 2018, Aapi, which used to be called the American Association of Physicians from India and is now called the American Association of Physicians of Indian Origin. And I thought that was a very smart move because that includes people like me who are of Indian origin but were trained in the United States. So Aapi says there are about 222,000 physicians of Indian origin in the US. We account for about 18% of all doctors in the US and a quarter of all the international medical graduates employed in the United States physician workforce. There are about 60,000 doctors of Indian origin working in the United Kingdom. So maybe Anupama, as president-elect of Aapi, and maybe we'll talk about women in leadership at Aapi, can you talk to us about why Aapi was formed and what it's doing to enhance the experience of physicians of Indian origin and, of course, our patients? Because I think our physicians work in areas that are relatively underserved in medicine, and I think Aapi represents physicians who really serve a vast population.
Right, Sujana. I agree with what you said. The physicians of Indian origin, as you said, we have about, as you said, more than 100,000. I don't know about 200,000, but at least more than 100,000 are physicians of Indian origin. And also 10% of medical schools have kids of Indian origin. And as per the statistics, they say that 1 in 7 patients is being managed by an Indian physician. So that's where we are. So we are every corner of the country. Mostly our physicians are in the rural hubs. They serve the underserved areas under different visas like J1, H1, and so and so. So a lot of physicians are working in the rural areas. So we are the skeleton of this country, giving the health care. So we are very proud being an Indian physician here. And to go back to the history of how AAPI was formed, in 1982, a bunch of physicians in Michigan, like when the early physicians of Indian origin, they moved here in the early 60s and 70s, right? So we had somewhat a racial discrimination. Those years, what I heard from those physicians who moved here in 60s, they said like they were put in, far away, not in the apartments where every other resident stayed. They were given a far away place to stay, and a lot of discrimination at the workplace as well. So that's how they came together and said, we need to have a voice for ourselves. So that's where we are in 1982. 8 physicians or 10 physicians made this organization. And look at now, we are like, more than 100,000 here, but we have life members about 14,000 right now, and many more annual members. And we have different sections, young physician section, medical student, resident fellow section, and we have the members. So it's a growing organization. We are 38 years old now. And so I was looking at what exactly, where are we in the pediatric world? So I kind of got this information, which is very recent. And look at the numbers now. 179,000 children got positive from July 9th to August. So August 6th, this is like a month. A 90% increase in child cases over 4 weeks. That is really alarming and scary to us who work in the pediatric world, especially in this era where we are about to start the schools. And look at the testing. Children made up between 3 to 12% of total state tests, and 3.7 to 18% of children got tested positive. Let me go to the next slide.
And just, I'm going to remind everyone while we're changing slides, people are watching from all over. We have people checking in from California, from Bermuda, from Las Vegas. Thank you very much for watching. Please share and tag your friends who would be interested, because I think this material that's being presented today by both of our guests is outstanding.
So, Sujana, look at the hospitalizations and mortality in children. So, if you look at those numbers, 0.5 to 5.3% are reported hospitalized. And look at the mortality, 0 to 0.4%. So it's really very low. So that way we are fine. Children are at low risk to have the disease. Occasional, there are cases with multi-system disease, but very rare. So based on these, I think all the societies are gearing up to start the schools. So here, and being a pediatric anesthesiologist, so I know we do COVID cases. I work at Children's Hospital of San Antonio, and we have almost 10% admission rate with COVID right now. And almost we were 0 in June. In July, we started slowly having at least 1 case a day in the OR.
Dora, can we talk a little bit about regular skin routines and skin cancer, and what people should be doing and looking at?
Absolutely. You know, a lot of times I get a question about, like, when should we start taking care of our skin? When does anti-aging start? And I kind of jokingly say it starts at birth. As soon as you're out, the time starts ticking, and everything you do reflects in your skin over time. So when we talk about sun protection, that's the single most important thing you do for your skin. 90% of how your skin ages is in your control. Only 10% of how your skin ages is genetic. And that relates to skin cancer as well. You may have a few genetic hits towards skin cancer, which isn't always reflected by skin color or skin tone, or even how easily you burn. But the more you protect, at a young age, it's physical protection. At all ages, it's about diet. But as we grow, it's really about being consistent in your sun smart behavior, which is so much more than just sun protection. It means trying to avoid midday sun, wearing a hat, wearing sunglasses, wearing physical protection when you can, staying in the shade, and then applying sunscreen of an SPF 30 or higher and reapplying regularly when you can. And of course, it means looking at your skin, because if you see something changing in your skin, it's on the outside. You should notice if it's changing over time. If it doesn't look right to you, show it to your dermatologist, because we'll either reassure you or we can send it to our friendly pathologist who helps us make a diagnosis. And an early diagnosis can be 98% or greater survival, and a late diagnosis, unfortunately, can be a lot of trouble and a lot of work, and often may really affect your overall outcome and survival.
Doris, it has to be 100 times worse for you, and I'm not sure, Valerie, if you can agree with this too. But first of all, I stare at people, right? Even when I'm talking to them, my friends are all like, "What are you staring at?" I'm like, "Okay, not a big deal, but I think you probably should get that thing checked out. Like that one." That one looks a little funny to me, and I'm not a specialist at all. But what I want to ask you is, we're going to show a slide of the different types of cancers, and because I've had people say, I had this red spot for a really long time, and I'm like, yeah, that one.
go see somebody. At least let them. I mean, I'm not a specialist, but if you're going to ask me, I'm definitely going to tell you to go see a specialist. But some of them you can kind of tell. So I'd love for you to take a look and for our audience to see this. And these are, I mean, well, actually, I'm going to let you talk.
Okay. Well, we'll start with the first one. Actinic keratosis is really sun damage, an early sign of seeing atypical or cells that are on the way to becoming skin cancer, but not quite yet skin cancer. So that's a warning sign to us that somebody's on the way. And the thing is, this can happen in all skin types, although it's more common in fair skin. You'll see all of these pictures in fair skin because these cancers are more common in fair skin than in darker skin. So when you look at the totality of skin cancers, whether you're looking at melanoma versus non-melanoma, basal cell, squamous cell, all the ones we're going to talk about, 35 to 45% of all cancers are in the skin in white people. When you look at Hispanics, it's 4 to 5% of cancers. In Asians, it's 3 to 4%, and in Blacks, it's 1 to 2%. So when you look at skin color, the rates of skin cancer go down, but it still needs to be diagnosed early. So actinic keratosis is sun damage that you can feel more than you can see. So it's often a rough spot, slightly red. When you go to the next most common type, that's basal cell. That's about 4 million cancers in a year. It's the single most common type of cancer, not just skin cancer, but any cancer. It's more common than breast, colon, lung, and prostate cancer combined. Wow. So chances are people are going to get basal cell. Again, I see this in people with skin of color, and what we have to look for is not color of the spot, but the overall look. So basal cells can have rolled borders, they can have a pearly look to them, they can be pigmented or non-pigmented in any skin type. So just because you have skin of color doesn't mean you're going to have only a pigmented basal cell, and because you have white skin doesn't mean you won't have a pigmented basal cell. So we need to pay attention to spots in the skin that are growing or changing and evolving over time. Then let's go over to squamous cell, because that's the next most common type. That's about 1 million new diagnoses every year. It can have a little bit of an ulceration or a scale in the center with redness at the borders. Melanoma is the one that scares us the most because it's the least common but most deadly. Over 100,000 of these every year, and about 1 to 2 people die every hour of melanoma. I had a patient who was African American who came in and he had vitiligo, and in his white spot he had an amelanotic melanoma. So it looked like exactly what you're talking about, a pink spot, but it started to grow over time. And they just sat there and they watched it because they thought because he had vitiligo and because he was African American, they didn't think that they were at risk of getting melanoma. And so unfortunately it was late. He's still doing fine, but it was work to get him on the treatments to help save his life. And we have amazing new treatments. Merkel cell is the one type of cancer that makes me tell you that you should have your skin cancer screening done by a board certified dermatologist every year. Merkel cell is the rarest of skin cancers. It's not sun related. It can happen in any skin type, and it can kill you in as little as 3 weeks. So, and it doesn't have a typical look. It can look like a cyst. It can look just like a bump in the skin. Depending on where it occurs and how fast it grows, it can be very deadly very quickly. So it's every time I look at the skin, every time I look at a spot, I'm sort of having a conversation with it and saying, are you a Merkel cell?
Lots of things happen in that black box of the pathology department that we really don't understand. One of that is about COVID testing. So we know about sticking a Q-tip up your nose. We know about getting some blood tests. Can you tell us, and I know, Valerie, you were on a great podcast that we'll show in a bit, but these are sort of the things people want to know is what are these tests doing, checking for? What are they telling us in this time?
So let's take a step back and look at what the coronavirus actually is. We've seen pictures of that spiky little virus, coronavirus because it looks like a crown, corona. And so when we're testing for coronavirus, there are different ways to do it. The most common way, of course, that we've heard is the swab up the nose, which is what we call viral RNA or ribonucleic acid test. And in that test, you try to get direct viral particles from the organism. We amplify them, and then we can tell whether or not a patient has the virus detected or virus not detected. So if the virus is detected, then you have a positive test for COVID-19 or SARS-CoV-2. But there are other tests out there, and that's the most common one that we're using. It is by far my favorite, no plug for any corporation, but it is a great test. The antibody test, which many of you have also probably heard about, tests antibodies. So what's an antibody? An antibody is a substance that we create in our bodies when we're exposed to an antigen. So what's an antigen? An antigen is a substance on that virus. So there's a substance on that virus that creates a reaction in our bodies with our immune response to create antibodies. All of these can be tested for COVID-19. Again, in my humble opinion, I think the best test is the viral RNA test, and the one that I would recommend people get if they believe that there's COVID positivity.
Valerie, you have done some amazing things on Twitter. You've advocated for not only teaching pathologists and other physicians about pathology, but about advocating for hashtag Black Women in Medicine. And you got a NASCAR driver on your team and got him to get his friends on your team. So can you talk to us a little bit about that?
So, this is very, very funny and very interesting. The night before my birthday, I decided that I was going to ask Bubba Wallace to follow me for my birthday. And I've been watching NASCAR since I was in middle school. So I've grown up on it. And when Bubba came onto the scene in the early 2010s, I was excited because I said, hey, look, there's somebody there who looks like me. And it's such an unusual thing, unfortunately, to still see in auto racing. So it was just so exciting to see him. And of course, you all know he's blown up. So hashtag MedTwitter got to work on my birthday, and a bunch of people tweeted at him and retweeted the tweet. And sure enough, he made a little video of following me on my birthday. So that was pretty awesome. And it turns out that he's actually very, very kind, wonderful man. Every once in a while, I'll send him a direct message that he'll answer. And so one of them was about, the HBCU movement and how, there have been women scientists, particularly Black moms, who have had their research halted, and it's very difficult. Now we're staying at home with our kids and trying to take care of things. And so, I said to Bubba, essentially, no pressure, but if you can donate to this worthy cause, we'd really appreciate it. And so not only did he donate, but then he got Tyler Reddick and Ryan Blaney to donate as well. So we had 3 drivers who donated to the cause. It was really awesome and much, much appreciated.
So can you tell our viewers how to donate and what the cause is for?
So the ARM, we call it the Army, Academic Research Moms, have a fund for medical and research trainee moms. It's on GoFundMe, so you can see it there on your screen. We have a goal of trying to raise $60,000 for these research moms who have had their research halted because of the COVID pandemic. So if you can get on GoFundMe and look for the ARM Fund for Medical and Research Trainee Moms, that would be awesome. And we appreciate anything that anyone can give.
Colon cancer is the 3rd most common cancer that we have in the country. Ultimately, the majority of cancers are without any symptoms, so they're completely asymptomatic. When they do get it to a little bit more advanced stage, you may have some abdominal pain, some bleeding, difficulty passing your stools, change in the stool caliber. So rather than being a big, healthy stool, it starts to be a narrow stool. Towards the latter stages, when we start to think about the spread of the disease, you're looking more at weight loss and constitutional symptoms like fatigue, and not really being up to any kind of task. You can see later signs of jaundice, particularly with extreme metastasis or tumor burden of the liver. So the presentation of the disease, majority of the times when we catch it early enough, is usually asymptomatic. And that makes screening much more important.
So, if they're asymptomatic, and I know we have a slide up there of the symptoms to look for that you talked about. And it is unfortunately still the 2nd leading cause of cancer deaths. And although the average age is older, we do see it, unfortunately, in younger people who may be disregarding some early signs and symptoms or don't meet the screening criteria. So can you talk to us about different ways to screen for colon cancer, even in asymptomatic individuals?
Absolutely. You touched on an important point, because our younger population usually sees blood in the bowl or have difficulty moving their stools, and they will commonly attribute it to hemorrhoids. So bringing those patients in and talking to them and getting their full story and addressing their symptoms are important. For those patients who don't have any symptoms, the primary care physicians become a particular ally to us, because they're able to send these people for screening methods. And you see on the slide there, we have simple things like fecal occult blood testing, where they give us some stool samples and we test for microscopic blood. Other simple things would be that kind of testing coupled with the sigmoidoscopy, because the fecal occult blood test only tests for right-sided bleeding and not so much left-sided bleeding. So adding sigmoidoscopy to the mix helps us identify left-sided colon cancers. And ideally, what we like to do is screening colonoscopies, where you prepare your colon by getting the colon clean the day before by drinking laxatives, and we bring you in and sedate you and look throughout your colon with a camera through the scope. The other thing that we have available now is Cologuard, which patients do at home. And it's not replacing this form of screening, but what it does is advocate for patients who are really resistant to getting colonoscopies, that if they get a positive test on the Cologuard, it really, we really encourage them to come in and let us do these colonoscopies so we could further evaluate them.
Dr. Gutierrez, maybe you can talk to us about who these long haulers are, what kind of symptoms they have, and what can we do to ensure that they have as good a quality of life as they go forward.
And you know what? I want to interject one thing. There are at least 2 recent articles about this concept of long haulers, which is why we wanted to discuss it. And we were so thrilled because we saw, Monica, your tweet on the topic, because it was people were supposed to be getting better and they weren't, and now we're realizing that there's a I guess not chronic. I don't know. I don't think we know, right? It's been 9 months. This is like a horrible viral pregnancy. It's horrible. Like we just don't know all the answers right now.
Yeah, we don't. And I think what we're just seeing what's come out of it. And one of the first papers that came out was one that came out of Italy that said, here are these patients that had COVID. For the most part, the ones in the study were not hospitalized, and that they looked at their symptoms 2 months later, and that 87% of people were still having ongoing symptoms 2 months after they had COVID. So these were moderate type COVID symptoms and still having then ongoing symptoms 2 months later. Fatigue, shortness of breath, inability to do exercise, aches and pains, headaches. So again, as I tell everyone, it's something that this is not anything that we've dealt with before, but I saw it as a way that this is not the first time that we've had a pandemic. And this is also not the first time that PM&R has come out to help patients with multiple issues. Actually, PM&R, the history of it is that some of it came out of both people surviving World War II and needing to serve those patients. And the other thing was the polio pandemic, also around the 1930s, 40s, 50s, that went a long time, and we had to take care of people who were in iron lungs and who were very sick and who had disabilities. And so I said, this is our opportunity now as physiatrists to take on a new pandemic and take care of people as early as in the ICU, where we know about PICS, or post-intensive care syndrome, and we care for people with symptoms in the ICU, to now where we have patients with these long hauler symptoms. So months after they've had COVID, they continue to have symptomatology. That study that you showed from the University of Indiana shows us, the top 5 symptoms that people are having. Again, the fatigue, overwhelming amount of post-viral fatigue, which has been shown that other viruses can cause. Muscles and body aches, shortness of breath, difficulty breathing, difficulty with concentration, people just saying, I can't find my words as like I used to, my memory's not as good as it was, and then hard to exercise, especially these are people that said, oh, I used to be able to go and walk miles or jog miles, and now I can't even walk around the block. And then headache, pain symptoms. And yes, if you go down and look at the list, anxiety, dizziness, and a lot of the anxiety is then coupled with the worry about what's going to happen to them, or what, you hear these horror stories, or you read about things of sudden death, or people doing better and then getting a lot worse. And so that made a lot of anxiety, plus the social distancing. They're not able to be around people or their friends, and they're at home and getting very anxious about their disease state. And so these are things that we're seeing. There's different clinics that have been set up, and I say some of it I'm used to working with because my day job is I usually take care of patients who have strokes or traumatic brain injury, concussions, and some of these symptoms are similar. They may have dizziness, they may have headaches, they may have a difficult time exercising or concentrating. And again, physiatrists take care of patients of all. We are trained in lots of disease states. We know about patients who need cardiac rehab or who may need pulmonary rehab or who have been in the ICU. So for that reason, I think that we're exceptionally well ready to take care of patients with the effects of COVID-19.